the panelists are going to read. If you click on the chat on all attendees and panelists, everybody is going to be able to see what you're texting. And if you have questions for Dr. Anderson or for Dr. Riyadh, please place on the Q&A, and we are going to answer them in the end of the talk. If you want to do your question live, please click on raise your hands, and then we can let you speak in the end of the meeting, and you can make your question yourself live. Okay, so I want to announce for you our next activities. This Monday, a little bit later, so 1 p.m. East, 7 p.m. European time, we are going to have the dear Professor Mary Cohen to talk about the echo on AVSD. So I'm going to send you the link for the registration for this webinar. And this Thursday, we are going to be on vacation. We are not going to have our big webinars, but next Thursday, on the 23rd, we are going to have a very nice webinar about tetralogy of Fallot. So I'm going to send you the link for that as well. And save the date, starting in August, every month, Dr. Silverman is going to have start his series correlating the morphology of the defects with the images. It's going to be very, very good. And I'm very happy to announce that Dr. Anderson is going to continue the series, and on next Friday we are going to have a tetralogy of Fallot. I'm going to place the links for registrations on the chat box, and we are going to send you by email as well. So that's it. Sasha, do you want to say something?
No, I'm okay. Thank you very much.
Okay, so I don't need to introduce you, Dr. Anderson, and so please, Dr. Anderson, you can start.
Well, good afternoon to you all, and here I am in London again, and earlier in the week, Sasha and I have pre-recorded the session you're about to see in just a few moments, but I'd like to share with you some very exciting information for me, because since recording the session we're going to see today, I've received a message from Wout Lammers. And those of you who have seen the early ones will know that for the embryologic basis of all the work I've done thus far, interatrial communications, atrioventricular septal defect, and now again, ventricular septal defect, interventricular communications, I've been basing the knowledge of embryology very much on the reconstructions that he and Jill Hickspoors have been making in Maastricht. And what Wout shared with me just a day or so ago was that one of the young students in his laboratory working in Maastricht has produced the most amazing YouTube video clip on remodeling of the embryonic interventricular communication. And I viewed that video clip yesterday, and it is perfect for understanding what I am going to be talking to you today, showing you the postnatal effect of remodeling of the interventricular communication. It is my understanding that Wout himself has registered and is watching this, what we will see very shortly, the recording that Sasha and I made earlier in the week. But I really would recommend to you this amazing video clip made by one of the students in Maastricht. She is enthusiastic. She's done a superb narrative of what happens to the embryonic interventricular communication. I'm going to find what the clip is, and Grace is going to send you all the email address for this clip. I don't know what it is at the moment, but by the time we've finished the recording, either I will send it to you, or if Wout is listening to this, then maybe Wout on the chat box will be able to give you the link to this short video clip. It doesn't last much more than 10 minutes, but it is fantastic. So now Sasha is going to show you our pre-recording showing what happens in the postnatal heart when we have remodeling of the embryonic interventricular communication. Sasha, over to you. Well, good afternoon to you all, ladies and gentlemen. This is Bob Anderson again, and I'm talking to you from London. And today we're going to complete our classrooms on the septal defects. So you know by now that we've discussed the fact that the normal heart has atrial, atrioventricular, and ventricular septal components. We've also discussed the fact that each of these components can be deficient in the setting of congenital heart disease. So in our previous classrooms now, we've looked at how there can be various connections, communications between the atrial chambers, and not all of them are true septal defects. So we discussed those in terms of interatrial communications. Last week, we discussed how the atrioventricular septum oftentimes was not formed, and how that resulted in a common atrioventricular junction, which was the essence of what we now call atrioventricular septal defect. So today, what I'm going to discuss with you is interventricular communications. And what I'm going to pursue again is the concept that if we understand cardiac development, we can now understand the anatomy of those various interventricular communications. You're all well aware, of course, that interventricular communications, or ventricular septal defects, as they are usually called, are the commonest congenital cardiac lesions. You all know they can be found in various formats. They can be found in different segmental combinations. So a channel between the ventricles is one of the features of most examples of functionally univentricular hearts. We know that ventricular septal defects are a feature of tetralogy of Fallot, and many times we find them in the setting of transposition. We also know that an interventricular communication is part and parcel of almost all examples we find when both arterial trunks arise from the right ventricle. But in my opinion, it's questionable as to whether, in that situation, we should call that channel between the ventricles a ventricular septal defect. And that's what I want to discuss with you today, as we also look at the arrangement in tetralogy of Fallot. But what
A lot of not. Can you share again?
component connects through the atrioventricular canal to the ventricular loop. Now, the ventricle started as the linear heart tube, and we discussed that that was derived from the first heart field. And we then discussed how it was the addition of new material from the so-called second heart field at both the venous pole and the arterial pole that produced the ventricular loop. And here we see that ventricular loop, and at its arterial end, it's giving rise to the outflow tract. It has grown into the pericardial cavity from the second heart field. And it is from this ventricular loop that we get formation of the ventricular chambers. And we see that in the next stage of development. And in fact, I've jumped 2 stages here, so I'm showing you a reconstruction at Carnegie stage 13, about 5 weeks of development. Again, we're looking at the heart from the front, but we can now see, we're looking at the reconstruction of the cavities, and you can see how it is developing the shape of the definitive heart. Still, however, the atrioventricular canal is draining only to the developing left ventricle. But what the reconstruction shows you is how the apical component of the developing left ventricle is appearing by the process that we call ballooning. And it is ballooning out from the inlet component of that ventricular loop, and this inlet component eventually will become the left ventricle. So ballooning from the outlet component of the ventricular loop, which supports the entirety of the outflow tract, you see the beginning of the apical component of what will be eventually the right ventricle. Now, I can show you this now in an episcopic data set, because as I've also discussed with you in the considerations of cardiac development, I'm in the position now that I can compare the reconstructions made by Wout and Jill with these episcopic data sets prepared by my other friend and collaborator, Tim Mohan, from human hearts. So this is an episcopic data set that I've cut to show you the overall axis of the ventricular loop, looking at it from the front. And this again is a human embryo at Carnegie stage 14. So I've cut it in such a way that you're looking at the base of the developing left ventricle. And there you can see the opening of the atrioventricular canal. Now, last week we discussed how within the atrioventricular canal we have the developing cushions, and I showed you how at this early stage of development the cushions lie edge to edge. At this stage, you see that that atrioventricular canal is looking into the developing trabecular component that will become the apical part of the left ventricle. And then you can also see, as I showed you in the reconstructions, how the apical component of the developing right ventricle is appearing by ballooning from the outlet component of the ventricular loop. And then the data set also shows you that the entirety of the outflow tract at this stage is supported by the developing right ventricle. And we know that with ongoing formation of the apical trabecular components, we get formation of the apical ventricular septum. And that will form the crest or the boundary of the primary interventricular foramen. And you will immediately see now that all the blood that is coming into the left ventricle has to pass through this primary interventricular foramen so as to reach the developing right ventricle, and then to pass out of the heart through the outflow tract. Now, what I've done here is I've taken that same data set and I've rotated it, and I've replicated the situation you would get echocardiographically if you looked at an oblique subcostal cut through the heart. So what you see there is the cavity, the right atrium. And because the atrioventricular canal is connecting exclusively to developing left ventricle, there is no communication at this early stage between the right atrium and what we see developing apical component of the right ventricle. Indeed, at this early stage, there is no formation of the right atrioventricular connection. What we've also seen, however, is that the developing right ventricle is supporting the entirety of the outflow tract. So again, all the blood passing through the heart, this early stage, must come through the embryonic interventricular communication. Now, this arrangement, as you see in the developing heart, where the atrioventricular junctions drain exclusively to what will become the left ventricle at this stage is dominant. The developing right ventricle already possesses its apical outlet components, but lacks its inlet. And this is directly comparable to what we see in the formed heart when we have functionally univentricular hearts with dominant left ventricle. In other words, either double inlet left ventricle or classical tricuspid atresia, which is absence of the right atrioventricular connection. And if we look at this computed tomogram from a patient who has double inlet left ventricle, I hope you can see the comparison between what I've shown you in the developing heart and what we now see here in the postnatal heart, with the obvious change that in the postnatal heart, the outflow tract has in fact divided, and one of the outflow tracts is committed to the dominant left ventricle. But in this computed tomogram in which we see the dominant left ventricle which has double inlet, we see that the developing right ventricle persists as the incomplete right ventricle. It lacks its inlet component. In this instance, it supports the aorta, as is usually the case with double inlet left ventricle. But as with that situation we saw in the developing heart, all the blood that is coming into the dominant left ventricle has to pass through the interventricular communication so as to reach, in this instance, the incomplete right ventricle and then the aorta. So that in the setting of tricuspid atresia or double inlet left ventricle, the interventricular communication, which typically we call the ventricular septal defect, has exclusively myocardial borders, because in developmental terms, it is the equivalent of what I've shown you in the developing heart. It is the primary interventricular foramen. And it will immediately be obvious to you, I hope, that in development, it is not possible for the embryo to close that primary interventricular communication, just as in the setting of double inlet left ventricle or tricuspid atresia, when there is transposition, the aorta arises from the incomplete right ventricle. It is not possible to close the ventricular septal defect unless another route is provided to get blood going into the aorta. So something has to happen during development so as to give that incomplete right ventricle its inlet. And the thing that occurs to produce that inlet is expansion of the atrioventricular canal. As the atrioventricular canal expands, however, there is still going to be a channel between the ventricles. But now, with expansion of the atrioventricular canal, that channel will become the secondary interventricular foramen. With normal development, there is then still further remodeling, such that the left ventricle acquires its own outlet, and only then is the embryo able to close the channel between the ventricles, and that channel which will be closed is the tertiary interventricular foramen. So now I'm going to show you the changes that occur with remodeling, and I'm going to liken those changes to the phenotypic features we see in congenitally malformed hearts with interventricular communications or ventricular septal defects. So let me take you on one stage during development of the human heart, and let me show you this section again through another of Tim Mohan's episcopic data sets. So this again is a human heart. We've moved on from one stage. We're now at Carnegie stage 15. And I'm obviously showing what we would call a 4-chamber section through the developing heart. So you'll recognize to your left hand the cavity of the right atrium, the right hand the cavity of the left atrium, and there, growing from the atrial roof, we see the primary atrial septum. And the primary atrial septum, with its mesenchymal cap, is growing towards the atrioventricular cushions. So there now is the atrioventricular canal myocardium. Note that already we can see that as the atrioventricular canal expands so as to give the right ventricle its inlet, the myocardium itself is going to be sequestrated to form the vestibule of the right atrium. But as it expands, it also gives the right ventricle its direct inlet. Now I've taken this particular data set, which now has malalignment between the developing atrial septum, developing ventricular septum, and I've reorientated it and I've cut it so that you can look at the base of the ventricular mass from the apex. So now you see the developing right ventricle to your left hand, the developing left ventricle to your right hand, and you note that there is the expanding rightward margin of the atrioventricular canal. And as the rightward margin of the canal expands, so the right atrium gains its direct connection with the developing right ventricle. And in so doing, the atrioventricular canal expands across the crest of the developing muscular ventricular septum. Now, if that expansion does not complete itself, we get the malformation of straddling and overriding of the tricuspid valve. And the essence of that malformation in the postnatal heart is malalignment between the developing atrial septum and the developing ventricular septum. And that's exactly what I've just shown you in the developing heart. So here is what we see in postnatal heart in the setting of malalignment of the ventricular septum. Because the atrioventricular canal has not expanded totally so as to give the right ventricle the entirety of its outlet, we have straddling and overriding of the tricuspid valve. And the phenotypic feature of this malformation is the malalignment between the ventricular septum and the atrial septum. And the other feature of this lesion is that because the ventricular septum carries the atrioventricular conduction axis, then because of the incomplete expansion of the right atrioventricular junction, we have an abnormal conduction axis with an anomalous atrioventricular node formed at the point where the malaligned ventricular septum meets the atrioventricular junction. So we can readily now explain straddling and overriding of the tricuspid valve simply on the basis of incomplete expansion of the atrioventricular canal. But of course, if development continues normally, then the entirety of the right atrioventricular junction is moved across such that it enters into the developing right ventricle. And then the atrial septum is able to merge with the ventricular septum, and there will be normal closure of the primary interatrial communication. But even after that has taken place, even after the right ventricle has obtained its own inlet, still the outflow tract remains supported exclusively by the developing right ventricle. And that is what we see here in yet another of Tim Mohan's episcopic data sets prepared from the human heart. Again, the human data set, I'm showing it to you, having cut in to replicate the oblique subcostal equivalent, as we would see in echocardiography. And now the right ventricle has achieved its inlet. There has been closure of the primary interatrial communication. The right atrioventricular junction is developing so as to have the tricuspid valve guarding the junction, but still at this stage, the entirety of the outflow tract, the aortic root, pulmonary root, separated by fusion of the proximal outflow cushions, remains positioned above the developing right ventricle. And although you can't see it terribly well in this particular cut, there is a channel here through which the blood, the left ventricle, passes into the right ventricle so as to reach the aortic root. In fact, I can show you the arrangement of that interventricular communication much better if we look at a developing mouse heart at a comparable stage of development. So this is another of the episcopic data sets prepared by Tim Mohan, this time from a mouse towards the end of the 12th day of development. As in the human heart I showed you, the right ventricle has achieved its inlet, which is developing the tricuspid valve at the right atrioventricular junction. But now you see rather nicely that the entirety of the outflow tract, the pulmonary root, the aortic root, is being separated by the proximal outflow cushions. You can see that the cushions are coming together. But since the aortic root is supported above the right ventricle, all the blood from the left ventricle has to pass through this persisting channel between the ventricles. Since the right ventricle has now achieved its own inlet by expansion of the dorsal part of the original primary interventricular communication, we can now call this the secondary interventricular communication. I can show you the relationship to the aortic root better if I take this same data set and I cut it so that we take a 4-chamber cut through the aortic root, the right ventricle, and the left ventricle. We're looking into the developing ventricles now from the apex. It's the same data set towards the end of the 12th day of development. And so to your left hand, you see the developing right ventricle. And there you see how expansion of the atrioventricular canal has given the right ventricle its own inlet. You see that at this stage, the atrioventricular cushions are in the process of fusing, and that right atrioventricular junction eventually will be guarded by the tricuspid valve. But you can also see very nicely that the entirety of the developing aortic root at this stage remains positioned above the cavity of the developing right ventricle. So as I've emphasized, all the blood that is coming into the left ventricle so as to reach the aortic root has to pass through this channel between the ventricles, and we can now call this the secondary intercommunication. And what I'd like to do now is to compare that situation to a postnatal heart, in which not only the pulmonary trunk, but also the aortic root are supported exclusively by the right ventricle. And this, of course, as you know, is what we call double outlet right ventricle. So I'm showing you a cut of the base of the heart that parallels the arrangement you've just seen in the developing heart. So to your right hand, you see the left ventricle, the mitral valve coming into the left ventricle. To your left hand, you see the right ventricle. And there is the tricuspid valve that is now guarding the right atrioventricular junction. What you see very nicely is that the right ventricle is supporting the entirety of the aortic root. And also, more anteriorly, it's also supporting the pulmonary trunk. So now, as in the developing heart, the stage I showed you just a moment ago, all the blood that is coming into the left ventricle, so as to reach the aortic root, has to pass through the channel between the ventricles. Now, at the moment, most usually this channel between the ventricles that I would like to call an interventricular communication is usually described as a ventricular septal defect. But the point I want to make is that it is not possible to close this channel between the ventricles. So is it justified to call this channel between the ventricles in the setting of double outlet right ventricle a ventricular septal defect? I think it's much better considered as an interventricular communication. And I'd like to develop this with you by looking at the situation in the setting of tetralogy of Fallot. So here, we're standing at the apex of the right ventricle in an autopsied heart with tetralogy of Fallot. We're looking towards the base of the right ventricle, and there you see the channel between the ventricles from the right ventricular aspect. That is where the surgeon will place the patch so as to correct tetralogy of Fallot, and that, I think, is the area that we usually call the ventricular septal defect. And it opens into the right ventricle between the limbs of the septomarginal trabeculation or the septal band. Now we can see the arrangement particularly nicely in this computed tomographic data set, prepared by my very good friend and colleague, Tony Levarchek, who works at the Medical University of South Carolina. And I think this data set shows you exquisitely the phenotypic features of tetralogy of Fallot. To your left hand again, you see the right ventricle. And there in the middle of the cut, we see the aortic root. We see the pulmonary trunk to the top, and very nicely, Tony's cut shows you the malalignment of the muscular outlet septum, which is the essence of tetralogy of Fallot when it also narrows the entrance to the subpulmonary infundibulum. And there you see the channel, which I believe most people in the setting of tetralogy of Fallot call the ventricular septal defect. Now, with these computed data sets, the beauty is that we can rotate the data sets and we can cut them in any plane that we want. So this is the same data set that Tony has rotated and cut it in such a way that you can see the extent of overriding of the aortic root. So there is the long axis of the ventricular septum. And the ventricular septum, of course, is marking the plane of the interventricular communication. So if we continue the long axis of the ventricular septum, that is showing us the geometric interventricular communication. We could, if we wanted to, call that the ventricular septal defect. But of course, nobody is ever going to put a patch in the setting of tetralogy of Fallot in the plane of the geometric interventricular communication. What the surgeon is going to do is to close off the area between the right ventricle and the overriding aortic root. And that, as shown by the double-headed red arrow, is the area that typically we call the ventricular septal defect. But I'd also like to emphasize to you a second area, because this is the area that is equivalent to what just a moment ago we called the secondary interventricular communication. It is the outflow tract for the developing left ventricle. It's the way the embryo passes all the blood passing into the left ventricle into the developing aortic root. And I can show you that by taking another mouse data set, another of Tim Mohan's reconstructed data sets that shows you this stage as the aortic root becomes reorientated so as to become committed to the developing left ventricle. So there is the aortic root. You see very nicely it's overriding the crest of the muscular ventricular septum. And now you can see how the embryo is now reorientating this secondary interventricular foramen so that it becomes the outflow tract for the definitive left ventricle. But we also very nicely now see that second area between the aortic root and the cavity of the right ventricle. And this was the area which the surgeon patches in the setting of tetralogy fellow. It's also the area that the embryo closes so as to commit the aortic root to the left ventricle, closing off that initial communication that existed between the aortic root and the right ventricle. And that means that when we return to double outlet right ventricle, as you see here, classical double outlet right ventricle with subaortic defect, there is the defect. There is no way that the surgeon can close that defect. It is not equivalent to the channel which just a moment ago in the setting of tetralogy of fellow we called the ventricular septal defect. What it is equivalent to is the secondary interventricular communication. And here we see a very nice example of such a subaortic defect in the setting of double outlet right ventricle, again in one of Tony Levarchek's exquisite computerized tomographic data sets. There is the defect. It's opening beneath the aortic root. The muscular outlet septum in this setting is exclusively a right ventricular structure. The defect opens between the limbs of septomarginal trabeculation. And when we rotate the data set to show you that the aorta is supported in its entirety by the developing right ventricle, what we see, that channel between the ventricles is the outlet for the right ventricle because it is equivalent to the secondary interventricular communication. And there is the area of which the surgeon will place a patch so as to tunnel the interventricular communication into the aortic root, and that is equivalent to what we call ventricular septal defect in the setting of tetralogy. And now we can make the direct comparison to what the surgeon does when repairing double outlet right ventricle. The surgeon creates a tunnel in the ventricular roof, and the embryo does exactly the same thing. And so here we see a later stage, just before closure of eventually of the interventricular communication. We're now in the 13th day of development. Still, the aortic root is positioned above the cavity of the developing right ventricle, but now the cushions are fused together to produce this shelf in the roof of the developing right ventricle. There is the plane of fusion between the cushions. And now that channel between the ventricles, the secondary interventricular communication, is becoming the outflow tract for the left ventricle. And so it is that secondary interventricular communication that becomes the outflow tract, and then and only then is the embryo able to close the persisting channel between the ventricles, which is the tertiary interventricular communication. Now, finally, we can get to consider isolated ventricular septal defects. Because if that tertiary interventricular communication is not closed, then we have the isolated perimembranous ventricular septal defect. And here you see that situation in a congenitally malformed heart. There is the typical central ventricular septal defect, and it represents the tertiary interventricular communication. And in fact, I can show you a mouse that has retained the tertiary interventricular communication. Another of the episcopic data sets prepared by Dr. Mohan. Dr. Mohan in these mice perturbed the furin enzyme. And we know that when there is perturbation of the furin enzyme, the mouse does not properly close the ventricular septum. And in this instance, mouse has committed the aortic root to the left ventricle. The outflow cushions have now muscularized to produce the supraventricular crest. The atrioventricular cushions have fused and are developing to give us a tricuspid valve. But there, in the roof of the developing right ventricle, we see the persisting interventricular communication. And when we look at this in a 4-chamber cut, we see a particularly important finding. Because there is the channel that remains open. It is the tertiary interventricular communication. The mitral valve is now providing the communication between the left atrium and the left ventricle. The atrioventricular canal has separated into the mitral valve, the tricuspid valve. The tricuspid valve is producing the communication between the right atrium, the right ventricle. But even though the aortic root has been transferred into the left ventricle, it has done so with a persisting subaortic infundibulum. The feature of the channel between the ventricles, however, is that it is roofed inferiorly by continuity between the tricuspid and mitral valves, despite the fact that second interventricular communication has been reorientated to form the outflow tract for the left ventricle. And this tells us, in fact, that when we see postnatal hearts with perimembranous ventricular septal defects, then the phenotypic feature is fibrous continuity between the mitral and tricuspid valves. Usually, there is also fibrous continuity between the tricuspid and aortic. That is not always the case. And in fact, it is the mitral to tricuspid continuity that we now recognize as the phenotypic feature of these defects. And whenever there is such mitral to tricuspid continuity, when the right atrium has committed itself totally to the right ventricle, always in this setting, we find the conduction axis postero-inferiorly, and that is why it is so important to recognize this feature of mitral to tricuspid continuity as the defining feature of the perimembranous defect. And so, when the mouse or when the human, when the embryo fails to close that tertiary embryonic interventricular communication, the communication itself is perimembranous. Its phenotypic feature, fibrous continuity between the leaflets of the atrioventricular valves. And we now know that the embryo is unable to close that defect when the muscular septum is deficient in the environs of that initial embryonic interventricular communication. And depending on which part of the muscular sept deficient, it can open to the inlet, the outlet, or when extreme, it can be confluent. And here is an instance where the defect is opening to the outlet of the right ventricle. The outflow cushions muscularized, they form the supraventricular crest. The defect, as an outlet defect, is opening to the right ventricle between the limbs of the septal band or the septomarginal trabeculation. The phenotypic feature of the defect, which is perimembranous, is fibrous continuity between the leaflets of the tricuspid and mitral valves. And when we look into the left ventricle of this particular heart, we see an important feature. Because you note that the muscular outlet septum, which is marginally deviated into the left ventricle, is interposing between the leaflets of the aortic valve and the tricuspid valve. But still, there is mitral to tricuspid fibrous continuity. And it is that mitral to tricuspid continuity that tells us that the defect is perimembranous, a perimembranous defect opening to the outlet of the right ventricle. But because we know it is perimembranous, we know the conduction axis will be running postero-inferiorly. Now, of course, not all ventricular septal defects seen as isolated lesions are perimembranous. And we can explain the formation of the other forms of isolated ventricular septal defect. Because in normal development, as the aortic root is committed to the left ventricle, part and parcel of that development, as you have seen, is fusion and muscularization of those proximal outflow cushions. And it is failure of that process that gives us the second type of defect. And we've also found that second type of defect in some of the hearts in which Dr. Mohan perturbed the furin enzyme. And here you see one such heart. We've sectioned it so as to replicate again the subcostal oblique echocardiographic cut. So there you see the developing aortic valve. There you see the developing pulmonary valve. And the feature of this mouse is that the outflow cushions are hyperplastic and they have failed to muscularize. And that means that the channel between the ventricles is now doubly committed and juxta-arterial. And it is that process, it is failure of muscularization of the outflow cushions that explains the juxta-arterial defect and explains its phenotypic feature, fibrous continuity between the leaflets of the aortic and pulmonary valves. Usually seen, as in this drawing, with a muscular posterior inferior rim derived from the trabeculations of the right ventricle, which produces protection for the conduction axis, but on occasions extending to become perimembranous. So normally, as you've seen, it's formation of the perimembranous of the membranous septum itself that completes ventricular septation. But even if that occurs, it's still necessary for the ventricular septum itself, the muscular septum, to coalesce. Because we know that the muscular ventricular septum is formed by compaction of embryonic ventricular trabeculations. And if those trabeculations don't fully coalesce, then there can be muscular defects anywhere within that developing apical septum. We can also have a muscular outlet defect when the muscularizing outflow cushions do not fuse properly with that apical septum. And it is these changes in formation of the muscular septum, either incomplete compaction or else failure of fusion with the muscularized outflow cushions, that explain all the muscular defects. In this heart again, another of Dr. Mohan's mice in which the furin enzyme was perturbed, we see that the muscular septum itself is incompletely compacted, giving us the so-called Swiss cheese variant. So on the basis of normal development, I do believe now we can understand all the types of ventricular septal defect along with interventricular communications. So what I hope I've shown you is that straddling tricuspid valve is readily explained on the basis of incomplete expansion of the atrioventricular canal. If the embryo fails to close the tertiary foramen, then we get the perimembranous defect. Should the outflow cushions not muscularize properly, then we get the juxta-arterial defect, whereas failure of compaction or failure of fusion of the outflow cushions with the muscular septum will give us all the various types of muscular defects. So now we can provide for you a categorization of ventricular septal defects that is totally coherent with what we understand development. The defects can be perimembranous, which typically open centrally, but which can open to the outlet, which can open to the inlet. When they open to the inlet, they can do so with alignment between the atrial and ventricular septum, or with malalignment. And it is malalignment of the ventricular septum with the atrial septum that underscores straddling and overriding of the tricuspid valve. Defects can be muscular, and they can open to the inlet, apically, or to the outlet. And they too can exist with malalignment of the outlet septum, or when the cushions themselves, the outflow cushions themselves, fail to muscularize, we can have the doubly committed juxta-arterial defect, of necessity then an outlet defect, which also can coexist with malalignment of a fibrous outlet septum, and which also can extend to become perimembranous. So on the basis of the development, I hope I've persuaded you that when we look at channels between the ventricles, always they can be described as being either muscular, perimembranous, or juxta-arterial. When we look at their direction of opening, they can open to the inlet, they can open apically, they can open to the outlet. On occasion, they can be sufficiently large to be considered confluent. They can be associated with malalignment. Malalignment between the atrial septum, muscular ventricular septum, produces straddling and overriding of the tricuspid valve. Malalignment of the outlet septum, of course, is the essence of tetralogy of Fallot. So the approach I've suggested, founded now on the basis of normal cardiac development, accounts for all variants of interventricular communications. Not always are they best described as ventricular septal defects, but hopefully the account I've given you gives you the basis to understand all of these variants, and equally importantly, to understand their phenotypic features. Thank you again for all your attention.
Thank you, Dr. Anderson. It was an amazing talk. I'm sure everybody learned a lot. I've learned a lot. And we can open for some questions before we go with Dr. Riyadh. I have one question for Ehsan. It's asking if you can define the cause of the double inlet right ventricle.
Well, it's obviously failure of expansion of the total failure of expansion of the atrioventricular canal, such that the developing atrioventricular canal never achieves that communication with the developing right ventricle, which we've seen develops from the outlet part of the ventricular loop. I think that we also have to take into account that when the atrioventricular canal fails to expand, it can still be that the atrial septum can divide that atrioventricular canal into right and left atrioventricular orifices, and it's that that gives us double inlet. Because I think that we have to think that an eccentric position of the atrial septum closing off the atrioventricular canal has to be the mechanism producing tricuspid atresia. I think we can also think of it going the other way, because we know we can also have absence of the left AV connection, and then only the right atrioventricular canal looks into the left ventricle. We can also have extreme expansion of the atrioventricular canal, and that will give us double inlet right ventricle. So all of these lesions are readily explained on the basis of expansion of the atrioventricular canal coupled with the formation, the position of the atrial septum itself.
Thank you.
We have probably, great. We have a question from Elatafi.
Yeah. Dr. Anderson, hello.
Hello, I can't see you.
Yeah.
You have your camera?
I will try.
He's gone now. Trying to put his camera on was a disaster. Bring him back, Sasha.
Yes.
You're muted now, Dr. Elatafi. You unmute.
Yes.
Ah, we can hear you now, or can we?
No.
Yeah. Now.
Ah, there we are. We see you. Hi.
Yeah. Hi. Thanks for this marvelous lecture. My question for the juxta arterial VSD, is there any embryological explanation why it will be subpulmonic or subaortic or doubly committed?
That's another very good question. We used to think that the juxta-arterial defect would always be doubly committed, but we now know that that is not the case. And I think it's all to do with the same mechanism as we see in tetralogy of Fallot. It's all to do with the mechanism in which the outflow tract itself becomes divided. Because I think if there is eccentric division of the outflow tract, such that the cushions that divide the outflow tract into the aortic and pulmonary components, if they are eccentrically divided, then in the doubly committed, the juxta-arterial defect, if those cushions don't muscularize, then the end of the cushions can still persist as a septum, and that itself can then fuse with the muscular septum in such a way that the defect itself stays subaortic rather than being doubly committed. So, and I think the same can happen the other way, the fibrous outlet septum can be deviated posterocaudally, and then the defect is very much subpulmonary. So I think it's a combination of failure of muscularization of the proximal cushions themselves, along with the way that the cushions then divide the outflow tract into the aortic and pulmonary channels. I mean, why that happens, I don't know. I think this is something we're learning much more about these things now. With the knowledge that we have, we can begin to look at these things. And what I've shown you with the exquisite data sets that Dr. Mohan has prepared, we're now in a position where we can look and we can chart these things much more closely. And I think when we begin to look at things these way, when we do the sort of things that when we look at normal development now in the fashion that Wout Lammers and Jill Hickspoors and their student has been looking at in Maastricht, I think we can begin to put all of these things together. We can ask the questions and hopefully we can come up with the answers in the coming years.
Yeah, thank you very much.
Grace.
Okay, Elisa, do you have one question?
She's...
Yeah, I don't think so. And Anand Patil, do you have one question? Okay. No? Okay, there's a question from the audience from Guillermo asking, does the outlet septum appears only in the setting of a double committed ventricular communication?
No, I think that we see the outlet septum specifically as a septal structure when the ventricular septum itself has not closed. So when the embryo does not close the tertiary interventricular communication, typically we're able to see then the fused proximal cushion mass as a septal structure. Normally, the entirety of that proximal cushion mass becomes the freestanding subpulmonary infundibulum. So when the septum, when an interventricular communication of an isolated ventricular septal defect persists, then we see that proximal cushion mass as a proper septum. It can be malaligned, antrocephalad as in tetralogy. You said next week we will discuss tetralogy, and I'll show the feature next week of antrocephalad malalignment of that proximal cushion mass. It can be deviated posterocaudally, and that's the typical situation we see with interruption of the aortic arch or with severe coarctation. Or it can become fibrous, and when it's fibrous, that's what we get when we get into the doubly committed and juxtaarterial defect. So it is that proximal cushion mass and what happens to the proximal cushions that determines what happens to what we then see as the outlet septum.
Okay, thank you. One last question before we start with Dr. Riyadh. It's from myself. Do you think that all ventricular septum defects are going to be able to be closed percutaneously? Do you think we are going to have a way to close all of them? Because, sorry, Dr. Surgeon, sorry about that.
I think that we have seen that it is possible to close most of the defects. I would be very surprised if for example, if you have a posterocaudal deviation, as you see with interruption of the aortic arch, I think it would be exceedingly difficult to close that defect. And if you did, it would be a disaster because you'd still end up with obstruction of the left ventricular outflow tract. I think the very fact that you can close these defects doesn't necessarily mean you should close them. There's a paper that's just been published within the last few months in the European Journal of Cardiothoracic Surgery describing closure of so-called doubly committed defects. I don't think that all the defects that these people described as being doubly committed defects have the phenotypic features of what I would call a juxtaarterial defect. With the juxtaarterial defect, I think it would be foolhardy in many instances to try to close such defects, because if you have a tiny fibrous outlet septum, it's going to be exceedingly difficult to anchor a device properly. So I think that as an anatomist, I shouldn't be saying what you should do, what you shouldn't do, but from what I know of the anatomy of the congenitally malformed heart, I think there are a lot of defects, I'd much rather have Sasha go in, see what he's doing and put a patch in the right place than to have the interventionist go in and try and put a device in. Just because a device can be put in, it doesn't mean it should be put in. But that's an anatomist speaking. Maybe Dr. Riyadh will be telling us much more about that.
We have a
question. You're going to have something to do on the OR.
I don't like to discuss about this point. So no, there is a question, Bob, from the YouTube channel that is live now. Is Khaled from Yemen in Saudi Arabia. And he asked me, in the context of doubly committed ventricular septal defect, Ross operation cannot be done because there is no more sleeve below the pulmonary valve?
That is a very good question. And again, I mean, it is foolhardy to say it can't be done. I think it would be very difficult to do it. And the implication that has already been made, if you did liberate the pulmonary trunk in that setting, then the pulmonary valve would be lacking a completely muscular sleeve. I don't know whether anybody has ever tried to liberate the pulmonary valve in that setting, but the inference that has been made, again, to me as an anatomist, is the correct one. It's very dangerous to say that something can't be done, because if I say it can't be done, someone's going to come along next week and say, I've done it. But I think that in that setting, it would be exceedingly difficult to liberate the pulmonary valve. It would be then very hard to sew the pulmonary valve into the left ventricular outflow tract if it was lacking what normally would be the back, the posterior part of what would be the adjacency to the aortic root. So I think it's a very good question. And I think that the answer is what the inference, it would be very foolish to try to achieve a Ross procedure in that setting.
Thank
you very much.
Great.
Now we are going to move on and we are going to introduce Dr. Riyadh AbuSulaiman. So he is a pediatric cardiologist from Riyadh in Saudi Arabia, and he is the past president of the Pan-Arab Congenital Heart Defect Association, and he's going to talk to us now about the VSD in a 3D echo view and a transesophageal echo view. Thank you very much for joining us, Dr. Riyadh. We're very happy to have you, my neighbor, here.
Okay, thank you very much, Grace, and all the panelists. I'm happy to speak in the Congenital Heart Academy today, and I'm gonna share my screen now. I hope you can see my screen.
Yes,
Yeah.
perfect.
Okay, so I'm happy to speak after Bob Anderson one more time. The first time we spoke together was in the first International Symposium, Anatomy and Echo Correlations on Congenital Heart Disease. This was in Saudi Arabia, 2003, almost 20 years ago. And then we recently also spoke together on the congenitally corrected transposition great arteries management outcome in infancy and adulthood in the Cleveland Clinic just last year. Today's my presentation is I'm trying to give the introduction on the international guidelines to use the transesophageal echo and 3D echo in congenital heart disease, and especially the VSD. We are going to show various types of ventricular septal defect, transthoracic echo, TEE, and the three-dimensional echo. Also, we are going to show some TEE guided interventions and 3D echo guided interventions as well, in addition to intraoperative TEE and three-dimensional echo. This is the guideline which was published recently on performing comprehensive transesophageal echo in children and all patients with congenital heart disease. And this very nice review. It showed the indication for transesophageal echo in patients with congenital heart disease, and there are three main indications. The first one is the diagnostic indications, preoperative indications, and the last one is TE guided interventions. Regarding three-dimensional echocardiography, it was recommended that it is used in device closure of various defects in the heart, visualization of catheters, measurements of defects. Also, it is being used effectively in monitoring and doing interventions like paravalvular leak, closing coronary artery fistulas, and other interventions. This is also a guideline from the American Society of Echo about the use of three-dimensional echocardiography in congenital heart disease at an expert consensus group. And what we have in this guideline is the imaging of the ventricular septum, and you can see that T and is very important in looking at the size, number, shape, location, and the guide, the intervention for closing them. Also, we have the recommendation from the European Society of European Association of Cardiovascular Imaging. It was published in 2014. Also showed that TE is very important in ventricular septal defect occlusion and membranous VSD occlusion, in addition to other interventions. So these are the types of the VSD. We will mention some of them in this lecture. The perimembranous defect, membranous inlet defect, muscular defect, doubly committed, and malaligned defect. And also we'll speak about intramural VSDs. This is the morphology for the perimembranous defect, and Professor Anderson gave us a very nice definition of this membranous defect. I'm going to show you a few examples of perimembranous defects and the associated abnormalities with this. So we'll start with the transesophageal echo. This is a fourth-chamber view, mid-esophageal view. You can see this is the left atrium here, the left ventricle, the right atrium, and the right ventricle. And this is the interventricular septum. Moving towards the five-chamber view, in which we will see the LVOT and the aortic valve. Here is the ventricular septal defect. And clearly here you can see part of the aortic valve is coming into the ventricular septal defect. So we have a prolapse of the aortic valve cusp. This is another view just to show the prolapsed cusp into the ventricle. And here with the color Doppler, although the ventricular septal defect is restrictive, but it is causing an exhaustion of the and distortion of the aortic valve cusp, and it will affect the competence of the aortic valve. So this is a mid-esophageal long axis view showing the left ventricular outflow tract, and this is the right coronary cusp, and this is the right coronary artery here supplying the right ventricle, and you can see how the right coronary cusp is prolapsing into the right ventricle. This is with color. It is restrictive ventricular septal defect. You can notice that there is trivial or mild aortic valve regurgitation. This is post-operative, and Sasha will be happy to see such nice repair here. So the aortic valve is almost competent. The VSD is totally closed, and the patient now is having only trivial aortic valve regurgitation. So aortic valve prolapse is one important association with ventricular, especially the perimembranous and the doubly committed, sometimes the muscular outlet VSDs. And this is the mechanism how the cusp of the aortic valve protrude into the right ventricle through the defect in systole as well as in diastole. This is a very nice three-dimensional echo showing cusp prolapsing into the RVOT here. And then we are looking from the right ventricular side, seeing that the aortic valve cusp is coming towards the right ventricle. This is another patient with aortic valve cusp prolapse. Not always we can see nice outcome of the aortic valve, but here there is a lot of distortion of the aortic valve cusp into the ventricular septal defect. And we can see on the color, there is a flow between the aorta and the right ventricle through the aortic valve cusp. So this patient has continuous flow in the pulmonary, in the right ventricle, which signify the rupture of sinus valsalva. So this patient has a rupture of the sinus valsalva. Here, another view by transesophageal, showing the cusp prolapse into the right ventricle and through the VSD. This is a short axis showing the right coronary cusp is severely distorted and protruding in towards the right ventricle. But most importantly, we see the long axis view, mid-esophageal. This is the aortic valve cusp is severely protruding into the right ventricle with the color. You can see the color through the cusp. So this is a rupture of the cusp, and it has the appearance what we call windsock appearance. This is three-dimensional echo showing the protrusion and the prolapse of the aortic valve cusp into the right ventricle. This is a beautiful repair from our great surgeons. You can see the aortic valve now has a trivial aortic regurgitation in the middle with the restoration of the cusp geometry. This is a long axis view. There is no ventricular septal defect residual, and there is a mild aortic valve regurgitation. This is three-dimensional echo showing the VSD is nicely closed. This is another patient with the perimembranous ventricular septal defect. This is the fourth chamber view showing slightly dilated left ventricle. And when we have the five chamber view here, we can see that the defect is underneath the aortic valve, and there is aortic valve to tricuspid valve continuity. This patient has a moderate ventricular septal defect. Then when we have the short axis, RV inflow, outflow, mid-esophageal view, we can see here that there is a fibrous continuity between the aorta and the tricuspid valve here. The VSD is opening centrally to the RV base of the heart. But when we look at the right ventricular outflow tract, we can see that there is hypertrophy of the muscle. So this is a double chamber or hypertrophied RV muscle bundle, in which it will cause right ventricular outflow tract obstruction. This is with color. You can see this is the VSD shunt between the aorta and the right ventricle. But here you can see there is a turbulence at the right ventricular outflow tract, signifying double chamber right ventricle. This is another patient with the perimembranous ventricular septal defect. This is the fourth chamber view, and you start to see the VSD in this area, in the membranous area. Then when we angle a little bit towards five chamber view, and we are looking at the left ventricular outflow tract, we notice that this patient had subaortic membrane. In addition to the ventricular septal defect. So this is subaortic membrane associated with ventricular septal defect. This is the five chamber view. We can see this is the aortic valve and the relation between the aortic valve and this subaortic membrane. And with the color, you can see there's a turbulence across the subaortic membrane. When we have the mid-esophageal short axis view, so this is the ventricular septal defect axis. But when we look carefully, we find again, this patient is similar to the previous patient I told you about. This is double chamber right ventricle or hypertrophied RV muscle bundle, in which there is turbulence across the right ventricular outflow tract. So in this patient, we have a VSD, we have subaortic membrane, in addition to double chamber right ventricle. This is another patient with the perimembranous ventricular septal defect. This is a mid-esophageal fourth chamber view, and you can see that there is a fibrous continuity between the mitral valve and the tricuspid valve, and there is the ventricular septal defect. When we put the color here, color Doppler, we see that there is a jet between the left ventricular outflow tract and the right atrium, as well as the right ventricle. So this is LV to RA shunt. This is what we call Gerbudi defect, in which we have a shunt between the left ventricle to the right atrium. Now, there are two types of Gerbudi defect. We have type A, which is a connection between the left ventricle to the right atrium through the membranous part. And this is quite rare. The more common one is the type B, in which there is a left to right shunt across the ventricular septal defect and then through the tricuspid valve leaflet to the right atrium. This is a deep transgastric view showing the left ventricular outflow tract, and you can see that this is VSD is opening towards the tricuspid valve leaflet. This is after surgical repair. There is no more left ventricle to the right atrium shunt, and we are left with minimal tricuspid valve regurgitation. And here from 5-chamber view, you can see that there is no left ventricular outflow tract obstruction, and the VSD is completely closed. Now, we will show you some cases in which we use the TE in guiding the intervention for ventricular septal defect. This is a perimembranous ventricular septal defect in which there is a left to right shunt. Here in this 5-chamber view, left ventricular outflow tract, you can see the size and the location of the ventricular septal defect, and you have to take care that and measure the distance between this defect and the aortic valve to guide the intervention. Here we have the wire loop through the ventricular septal defect through the ascending aorta, and then here in this clip you can see the attachment. The device is still attached with the wire before release, so we can tell about the device position. Now it is very nicely positioned away from the aortic valve, and it's actually closing the ventricular septal defect nicely. This is the after release, and you can see the device is stable position. There is a flow through the device, which is usually found in these interventions, and usually it will close with time. This is the final. This is 4-chamber view. This is the final, and you can see there is some residual leak through the device, which will heal in the future. This is a patient with similar to Gerbudi defect, in which we have left ventricle to the right atrium shunt through the tricuspid valve leaflet. This patient was taken to the cath lab to try to close this VSD, and this is the long axis view showing the VSD in relation to the aortic valve. So after that, we can take the measurement for this VSD and the difference between the borders and the aortic valve. Then we have three-dimensional. We can do three-dimensional echo to look at the VSD in relation to the aortic valve, and also to look at the geometry of the ventricular septum. So here, in this still image, you can see the VSD is somehow triangular in shape. This patient went into closure by the device, and this is the device in the left ventricular outflow tract. It's very nicely seated. It is away from the coronary cusp of the aortic valve, and in this beautiful view, you can see as the device is in a stable position between the left ventricle and right ventricle, straddling the septum very nicely away from the aortic valve. So this is a successful VSD device closure. Not all the VSD device closure is successful, and we have to pay a lot of attention. This is a perimembranous VSD in which you can see there is a continuity between the mitral and tricuspid valve, and that's the VSD in this area. It is a membranous part of the ventricular septum. And this is a short axis view showing the VSD in relation to the ventricular septum. And then there is no right ventricular outflow tract obstruction. So this patient went to the cath lab, and then they placed the device into the ventricular septum. You can see the device here is not well positioned in the septum, and actually it is touching the aortic valve. They tried to reposition the ventricular septal device, but actually now it is anchoring the aortic valve leaflets, and actually it is causing aortic valve regurgitation. So this patient had retrieved the device, and thanks for our surgeon, they did a beautiful job here, and this patient went for VSD closure, and you can see here the VSD is closed and the aortic valve is competent. Now we move to the muscular type of ventricular septal defect. These are very nice images from Professor Edward from Mayo Clinic. This is a large ventricular septal defect, which we can see from the left ventricular side. This is another patient with a smaller defect in the between the left ventricle and right ventricle, and actually this VSD has been spontaneously closed. We'll see some intervention for our muscular VSD. This is a patient with a mid-muscular ventricular septal defect, and there is a left to right shunt here, and the shunt actually is directed towards the tricuspid valve to the right atrium. Here, the transesophageal echo can help us in guiding the intervention, and you can see this is the wire loop across the ventricular septal defect, so it's in a good position. And here with the three-dimensional echo, you can see the wire is coming through the tricuspid valve towards the ventricular septal defect, and they are looping around. Now, the device is released, and it's in stable position, and actually very nicely sitting. This is a coil closure of ventricular septal defect. It's away from the aortic valve as well. Hybrid procedure can be done between the surgeon and the interventional cardiologist. I will show you one case we have done as a hybrid procedure. This is a baby who has a large ventricular septal defect, which was thought to be closed better by muscular device. And as you can see, there's a large ventricular septal defect with a left to right shunt in a 4 kilogram baby. I will take you step by step for the periventricular approach. Here, the TE can guide us regarding the needle puncture for the right ventricle. Here is the needle is and the sheath is introduced to the left ventricle through the ventricular septal defect, and then the wire here, you can see the wire in the left ventricle, and then after that we introduced the device. The device now is completely released in the left ventricle. Repositioning of the device to straddle the septum. It is now straddling nicely the left side and the right side of the ventricular septum, and this is with the color, and you can see there is a residual leak through the device, which will eventually close with time. This is another patient with muscular defect, but in this case, this patient has a truly apical ventricular septal defect, in which there is a large defect here in the true apex of the heart. This is with the color here. You can see there is left to right shunt across the VSD. This is a long axis view showing the device from another perspective. The patient has a successful surgical, it was difficult surgical closure of this VSD, but it was successfully closed. And here there is, in the long axis view, there is a mild leak from one of the borders of the VSD, but overall this is successful operation. When we speak about the residual ventricular septal defect after surgical repair, it depends on the size of the ventricular septum defect. If the size is less than 2 millimeter, usually this will resolve spontaneously. If the VSD is about 3 millimeter, this is typically not hemodynamic significant, and usually resolve with time. But if your VSD is more than 3 millimeter, between 3 and 4 millimeter, this require careful assessment and probably blood oxygen saturation analysis for better determination of the need to go for bypass or not. If the QPQS calculation is more than 1.5 to 1, or the residual VSD is more than 4 millimeter, then it is actually warrant another attempt for VSD closure. Talking about VSDs after surgical repair, we need to speak about intramural ventricular septal defect. These defects usually occur after malaligned ventricular septal defect closure in tetralogy of fellow double outlet right ventricle, and sometime in conotruncal abnormalities. So the ventricular septal defect patch is anchored to the right ventricular trabeculations rather than to the free wall. So this is the patch here is anchored to the trabeculation, and then after that the blood will go through the trabeculation from the left ventricle to the right ventricle. In this diagram here, this is the correct way of closing ventricular septal defect in this malalignment type. This is a patient who has a double outlet right ventricle, and he has a VSD closure. And you can see this is the patch of the ventricular septum, and you can see that shunt between the left ventricle to the right ventricle through the tip of the patch underneath the aortic valve. Then we did for him three-dimensional echocardiography, and this is the left ventricular outflow tract. This is the aorta here, and you can see the VSD is sitting just below the aortic valve leaflet. This is a zoomed view. This is the VSD, and this is the patch, and this is the malaligned septum. When we look at this VSD from the LV side as well, it is like rectangular in shape. So this patient went for device closure of this intramural VSD, and it actually here it is successful closure of this intramural VSD, and we have only few residual through the device which will close eventually. This is a 3D of the LVOT. This is the LVOT here, and this is the device sitting nicely in the intramural VSD. Speaking about the role of transesophageal echo in pediatric cardiac surgery, we reported our experience a few years ago. We had over 1,000 patients. We did pre and post-operative TEE for more than 2,000 transesophageal echoes. Our surgical revision for all kind of congenital heart disease was about 3.9%. which is really a good revision rate. Of that 1,000 patients, we have 263 VSD cases, and there were only 6 cases, about 2%, which needed surgical revision in the same setting. Now I'll speak about doubly committed or juxta-arterial ventricular septal defect. This is a very rare type of ventricular septal defect in which there is a fibrous continuity between the aorta and the pulmonary valves, and the defect is in between the limbs of the septal band. This is another view, like the base of the heart here. This is the membranous septum between the aorta and the right ventricle. But the outlet septum here, when we have a doubly committed VSD, it will be in this area. So we will have fibrous continuity between the pulmonary valve anteriorly and the aorta posteriorly. I will show you one patient with doubly committed VSD. This is a transthoracic echo showing there is a large ventricular septal defect here just below the aortic valve. And when we have a short axis view towards the pulmonary valve, we can notice that the VSD is sitting below the pulmonary valve. And with the short axis view, you can see that there is a fibrous continuity between the pulmonary and the aortic valve, and the VSD is in the outlet region. This is the transesophageal echo of the same patient. This is a 5-chamber view. The LVOT and the aortic valve is narrowed. And this is the shunt between the left ventricle and the right ventricle through the VSD here. This is a long axis view showing the aorta and the ventricular septal defect. And here the VSD is also between the aorta and the pulmonary valve. The patient went for surgical repair of doubly committed VSD, and it was repaired beautifully. There is no residual leak of this VSD, but you can see that the left ventricular outflow tract is narrowed. And usually in our experience, this narrowing will improve in the future, and the patient will not have any obstruction. In the same OR, you have to make sure that there is no obstruction to the pulmonary valve or RVOT, because sometimes doubly committed VSD surgical repair can result in pulmonary or suprapulmonary stenosis. Regarding malaligned VSD, as Professor Anderson mentioned about the VSD itself and the relation between the interventricular communication, usually the surgeon will close this part of the VSD, not the true anatomical VSD. This is an adult patient with VSD here, and you can see there is malalignment and there is aortic override of the interventricular septum. Here in the zoomed view, you can see there is a left to right shunt and actually bidirectional shunt in this patient. This is a long axis view, transesophageal echo showing the aorta override the interventricular septum, and there is no aortic valve regurgitation. This is a nice three-dimensional echocardiography showing the aorta here is overriding the interventricular septum. This is another view in which there is malalignment between the aorta and the ventricular septum. This is the LVOT from the left ventricular side. So this is override of the aorta to the interventricular septum, and you can see the right ventricle from this area here. We have done transesophageal echo in conjoined twins. This is our children's hospital here. Our children's hospital has the largest experience in the world in separating conjoined twins. And part of this evaluation is that they have to evaluate the cardiovascular system, because cardiovascular system abnormalities can preclude the separation of the patients. So we have in this study here, this is the TE for one just before separation, because the patient has fused pericardium and they have congenital heart disease. We looked at 42 sets before separation, and we analyzed the cardiovascular abnormalities. This is one of the patients. This is a TE of the patients. They were around 1 year of age before separation. And you can see that there is a membranous type of ventricular septal defect. Again, also we can see there is right ventricular hypoplasia. This is the color for the same view, for chamber view, and you can see there is a left to right shunt. This is almost long axis view with a left to right shunt across the VSD. This patient went to a separation, and later in life we did ventricular septal defect closure, and the right ventricle was receiving the whole systemic return. So in summary, echocardiography for ventricular septal defect, as you know, the ventricular septal defect is the commonest congenital heart disease with different morphological types. Careful evaluation by echocardiography is feasible in most cases, utilizing transesophageal and three-dimensional echo. At interventional procedures are recommended. Intraoperative TE and three-dimensional echo will guide the surgical plan and ensure the successful repair for congenital heart disease. Thank you very much, and enjoy my heart collection.
Thank you very much, Riyadh. That was amazing. The comments on the chat are very good, and thanks a lot. I think that personally, I think that the introduction of standardize the transesophageal echocardiography increase dramatically the rate of quality of assistance for congenital heart patient. As in our experience, we had all the patients who receive cardiac surgery receive pre-op, not as a standard, but all of them receive post-op transesophageal. I think the experience with the VSD, it's fantastic. Also, we have done more than 20 cases of percutaneous closure of, perventricular closure of the ventricular septal defect, and we think that is a very good opportunity for patients that have a good indication. And for muscular VSD, I believe, as you present, that also for small child, we have to think that we can proceed with this technique. So thanks again. I have one question for you, and someone for Grace. If you think that you can close percutaneous Gerbode defect or not.
Yes, we have experience with cases with Gerbode defect, and I have maybe shown you one or two already. We find that PFM coil is sitting very nicely in the pouch of the VSD as it causes some aneurysm. And then it will obliterate actually the left to right shunt as well as the left ventricle to the right atrium shunt through the tricuspid valve leaflet. So our experience has been really good with these type of defects.
Thank you. Grace.
I am the most non-invasive interventionist ever. I think it's mostly a surgical defect. I think the surgical correction is better.
Thank you. So we have some questions from the question and answer.
We have some people that raised their hands. Maybe we can let them speak.
Let's see. Coming to
Regina, Mariam. Dr. Silverman is there.
Oh, my God. Norman.
Okay, can we start with Regina?
Regina.
Regina, do you want to make your question? No.
Abda. Regina.
No as well?
Sorry, we start with Norman Silverman. Hi, Norman.
Very nice talks. A brilliant talk, Bob. Thank you very much. And I wanted to ask your incidence of heart block with perimembranous VSDs. In the United States, are working with the people from HA Medical, they've stopped doing VSDs because of the high incidence of heart block. What is your incidence of heart block with perimembranous VSDs?
Okay, regarding perimembranous VSDs, using HA or the ambulatory device, we stopped using it because it has a high incidence of heart block. We had 2 patients in a series of around 45. So we are using other type of devices like PFM coils, which really very soft and doesn't really has an incidence of heart block.
Okay, we have.
Sorry, just to complete the rationale when we started to close VSD is that as is the high pressure chambers, we should have devices very, very, very stiff that would have a lot of force to close it enough to move. And this was probably the reason why the conduction system was damaged. Then we stopped doing that, and then they started to develop a second generation of these devices. They are much softer, and they're very gentle to the conduction system, and the design is a little bit different. If you see the papers from China, I think they were the first ones to report the second generation. They have less than 1% of heart block. So it's compatible with the surgical heart block incidence. So now we started again to close a VSD, perimembranous VSDs on the cath lab.
Okay.
The problem, can I make a comment?
Yes, sorry.
I think the problem with all of this is that how in a perimembranous ventricular septal defect, of necessity, the conduction system is related to one of the borders of the defect. So however you put a device in, whether it's strong, whether it's soft, whether it's hard, it is going to lie against the conduction axis. And when you say that the surgical closure is 1%, I think surgeons knowing what they're doing will never produce heart block with a perimembranous VSD because they're going to put their stitches through the leaflet tissue of the tricuspid valve. So, I mean, that's what I said to start off with. It can be done. And it is being done. I think in the fullness of time, any device put in is going to have some relationship to the conduction axis, so time will tell. I would much rather have the surgeon go, if I had a grandchild needing a ventricular septal defect closed, I would much rather Sasha went in and put a patch knowing where he was putting it. But that's the anatomist speaking.
Okay.
Sasha, now you have to tell us what your surgical incidence of VSD.
This is a special moment for me, please. This is a special. Okay. Mariam from Libya, come on.
Yes, good afternoon. My question already answered about the risk of complete heart block with the device closure of perimembranous VSD. Already answered. Thanks.
Okay, thank you. Ali from Jordan.
Yes, hi. It's Ali Al-Halabi. I'm interventional pediatric cardiologist. Now, 2 things. First, I want to support Grace regarding perimembranous VSD closure, transcatheter, and with the new devices that are now the modified devices. Though I respect my old teacher, Dr. Anderson, but still the shear forces are differing, and in the new devices, though they anchor there, but the pressure on the conductive system is much less, and this is why the new studies and new publications are indicating that it's equal. The heart block is equal to post-surgical perimembranous VSD closure. Now, one other thing is about Garbudi defects, because there was something about Garbudi, and we have to differentiate between the 2 types of Garbudi. Now, the one that Riyadh presented is the one that the shunt is through the tricuspid valve leaflet, and this is amenable to transcatheter closure probably much more than the one that is above the tricuspid. That was explained very well by Dr. Anderson about the types, which is the rare type, the one that with a direct shunt between the VSD and between the left ventricle and the right atrium. Thank you very much.
Thank you, Ari. We have Takanari Fuji. You want to talk?
Thank you very much. I'm Takanari Fuji, pediatric interventionist from Japan. And I have one question about the residual intramural VSD you mentioned in your presentation. And we have some same patient in my experience. And my question is about is there any concern to do the device closure of the intramural residual ventricular septum defect, and which device is the most appropriate for the procedures?
It's a very nice question for an interventional cardiologist. But I would say that in our case, we used PDA device. I have I can see one of the questions they are asking about which is better to use the dimension of the VSD, whether by T or by angiographic. I think two-dimensional and three-dimensional echo will clarify very well the size of the VSD. I can see some of the interventional radiologists use different types of devices according to the shape. But usually it is a successful operation. Sometimes you need to put more than one device to close the intramural, because it's wider than the usual VSD. It's not like circular.
Yeah, and what I have really concern about the device embolization, because which type of VSD maybe can be directed easily by the device. So what do you say about this risk of the?
So after you place the device in the VSD, you have to look by TE. Is it anchoring the whole area? Is not affecting the aortic valve? Is it, and then you can be reassured that this is a type, the correct size of the device.
Thank you very much.
Okay, now we have Monem Ayad from Egypt.
Hello.
Hello.
Thank you very much for the very nice lecture and the organization. I have a question about perimembranous VSDs with prolapsing right aortic cusp. What are the current indications for repair? I know we should wait for trivial aortic regurg to occur, or should I want to know the current indication. Thank you very much.
I think, Bob, can you please add some information about the real impact of the aortic valve and the VSD in the lobri pezzi, or I don't know.
I think the answer to the question is that you need to, ideally, you need to repair them before the leaflet starts prolapsing. I mean, it's one of the reasons given why alleged spontaneous closure, but it's very bad when the defect closes because it's a prolapsing leaflet. So, I mean, it happens. We know it does. But and again, I think if you see any, for the juxta-arterial defect, that's the one where more typically you get prolapse, although you do also get it in the perimembranous defect. But it's an immediate indication for closure. If you see beginning, once it's started prolapsing, you're in bad shape, aren't you? Then Sasha, you would know, you'd have to resuspend the leaflet, would you not?
Yes, yes. No, the idea for us, we call the Venturi effect. When the valve is over the VSD and the Venturi effect start, we found a fibrotic or rigid aortic.
And this is a reality on the low and medium income countries, because on Europe and the US, you usually have the early diagnosis and you usually don't let this happen. But for us, we get these patients when these things are already there. So we needed to learn how to deal with that.
Well, I guess you have to do something to resuspend the leaflet then. You'd certainly have to pull the leaflet out. If you don't repair the prolapsing leaflet, you're going to close the VSD and you're going to end up with aortic regurgitation, are you not?
So now we have Milad. Welcome. Hi, Milad.
Hi, Sasha. Hi, everybody. Actually, the discussion for the intervention closure or percutaneous closure or VSD, there's different point we have to look for. There is no single answer for this question or for this comment. What we want actually to seal totally the VSD, to have a device not make a pressure on the conducting system, and to have a small soft device what we can introduce, because these kids usually they are small, so the axis size and the axis issue is an issue for intervention. So there is no single answer, and to avoid AV block, actually nowadays there's many soft devices. PFM coil, what Riyadh mentioned, it is very good in closing perimembrance VSD, and it almost nil for the AV block in our experience. And also the perimembrance who has an aneurysm, we put the devices to anchor the aneurysmal tissue, not the septum. So the problem or the risk of heart block is very minimal, almost nil also. Having said, there is other problems, for example, hemolysis with BFM coil, which is also an issue we have to think about. And how the morphology of VSD would make us to choose which device. There is more than 10 devices what you can use for VSD closure, but depend on the morphology and the position of the VSD. So there is no single answer for this question.
Thank you.
Can I make a comment there? Because I think that what Riyadh showed us in his three-dimensional visualization of the defect, I think that's exquisite. And what he's showing us now is you can see much more. You can, and he showed when you put the device in, you can see where it's lying. And Riyadh, you must be able to comment on this. You must be able to see the relationship of the device to the posterior inferior margin of the defect. You know where that is the greatest danger area. I repeat again, you can't put a device in without it coming into some contact with the area of the conduction system. But I guess, Riyadh, with what you're doing with your three-dimensional visualization, you are minimizing the risk as best you can.
Exactly. You need to look at all the borders of the VSD and see if there is any stretch or offer. And the most important is not to use oversize actually devices, because this is the problem when you have oversized device. You try to be protective and completely closing the VSD on the expense of stretching the VSD and the lower border of the posterior inferior border of the VSD. So it can be seen actually by a careful three-dimensional echo.
And I think the other point that Riyadh showed, I thought his pictures were exquisite. And when you know what you're looking for now, when you appreciate the features to be looking for, you can see them all. And the resolution of the machinery these days is spectacular, and so much has changed since we started with all this. And I think it's showing that how well you can now visualize the phenotype of what's going on. Is that not fair also, Riyadh?
Yeah, I mean, we are happy with the new technology, and it's becoming very nice. And it's as you can see the heart in front of your hand.
Carlos, welcome to Carlos Troconis. Ciao, Carlos. Carlos, are you okay? No? We have Latafi, Gadalla.
Yeah.
Yes.
My question is, does the introduction of transcaster closure of VSD change the indications, especially for a small VSD? I mean, we are surgeons. When we are faced with a 2 to 3 millimeter VSD, we are reluctant to close it. But we find our colleagues of interventional cardiology, they are so encouraged to do it just for fear from infective endocarditis. Is it right to do that?
It's very important to have the indication for closing the VSD. You have to take history, physical examination, chest X-ray, the history of the patient, in addition to echocardiographic properties of the hemodynamic and the hemodynamic effect on the heart. So a small VSD which doesn't cause left ventricular dilatation really is not for closure. If you are in doubt, then you can take the patient to cath lab and measure the QPQS, and it's well known that 1.5 to 1 is not less than that, is not an indication to close a VSD.
And for the issue of infective endocarditis, for the natural small VSD and the device?
The endocarditis for a VSD is very rare, and then you should not forget that device closure of VSD is not a problem-free, and it's not complication-free. Sometimes you have more disaster than what you think about.
Okay, now thank you. We go to Zara Kajali, is the child who is talking.
Hi, I have a question from Dr. Anderson. What's the origin of membranous part of interventricular septum, the embryology of this part of septum?
Sorry, say it again. What is the origin of?
Membranous part of
the membranous septum. Yes. The membranous septum is developed from what are called the tubercles of the atrioventricular cushions. So the atrioventricular cushions form the aortic leaflet of the mitral valve. They come together and they contribute to the septal leaflet of the tricuspid valve. And then as the proximal outflow cushions narrow that space between the root of the aorta and the right ventricle, so two additional tubercles from the atrioventricular cushions close the space, and they become the membranous part of the septum. So the mitral valve, the tricuspid valve, the membranous septum are all in fibrous continuity. And that's why it is tricuspid to mitral continuity, the retention of that mitral to tricuspid continuity that is the phenotypic feature, usually with aortic continuity. And Riyadh showed you that also. But on occasion, as I also showed you, you can have only mitral to tricuspid continuity. So that now should be the final phenotypic feature. But they're all derived from the atrioventricular endocardial cushions.
Thank you. I think that for today, we have 2 hours discussing by a fantastic speaker. Thanks a lot. I will give the last words to Grace. Thanks, Bob. We will see next week with the trilogy. Riyadh, we will see this evening, probably, for the meeting. And then...
Thank you. Thank you very much.
Guys, thank you very much. It was an amazing meeting. I think it worked very well to join morphology and image. We are very happy for this experience. We are waiting for all of you on Monday with Dr. Mary Cohen. We are going to discuss AVSD on echo images. It's going to be awesome. Please register and join us on Monday. And next Friday, we are going to have Dr. Anderson talking about morphology and embryology of tetralogy of Fallot. Thank you very much. It was an amazing. Thank you for the speakers and to all of you from all over the world that were able to be with us and interact and make your questions. Thank you very much.
Hi, Bob.
Ciao.
Bye, Dr. Silverman. Bye-bye.
Thank you, Riyadh.
Bye now.
Very good.
Thank you very much.
Congrats.
Thank you very much.
Congratulations.